So thank you very much for the opportunity to present my recent work. I will start with an overview about my journey, my academic career journey up to here, and then second part, I will elaborate more on my care work and my future plans. Okay, so here is the campus where I studied nutrition science at the Hebrew University in Jerusalem, in Israel. The campus here is the agriculture campus of the university, and it's in central Israel. It's not in Jerusalem. So here I learned my nutrition science and all the food science and food tech. So this is where I graduated my undergraduate degree. I continued to do an RD, a registered dietitian, and I worked at the geriatric recovery and rehabilitation unit in Tel Shomer in Israel. It's a big hospital. In this unit, people, after being hospitalized, they need some follow-up, a medical follow-up. So they go to this unit to have more recovery and rehab. So I was a nutritionist there. I focused on doing the assessment and the nutrition, treatment. And the idea is that the patient that has a better nutrition status also has better medical treatment, and the recovery time reduces. So that was my role for 4 years. I did also the sport nutritionist a certificate. Then I continued to medical science at Hebrew University. This is the building. I focused on also epidemiology and focusing on genetic epidemiology of chronic diseases, which include osteoporosis, hypertension, and obesity. My PI advisor back then, it was Professor Gregory Lifshitz. He had a cohort of 400 families with 2 to 3 generations that he followed up. And we could do some variation within the family and between the family and within the family to measure the extent of the genetic of bone mass density, bone size, and bone geometric, and also blood pressure and fat mass. So we could measure and build a model that measure the extent of the genetic and versus the extent of the environment component for those traits. These families were quite naive. They were not exposed to medication and not technology. So the aging process was quite natural. They are not from Israel. They are from West Russia, near the Volga River. They call Chuvachim, if somebody is familiar. So he worked on this, and I helped him with the measurement of the bones. Then I continued to pursue my public health degree, PhD degree in Austin. It was part of the University of Texas Health Science Center. I did major in behavioral epidemiology. The focus was on what drives people to smoke, alcohol use, physical activity, obesity, and breastfeeding. So all this behavior were the outcome, and my training was to measure the behavioral that caused those outcomes. It can be a social interaction, it can be sensation seeking, and anxiety, social status, all kinds of factors that define behavior. So my dissertation was on acculturation, body image, and breastfeeding. Body image, it's the whole life, so it also can be for aging. And I was trained to do big data and survey analysis. I was interested to do some analysis comparing Mexican women. So I reached out to the NHANS, that they have a big survey in Mexico that's very similar to the NHANS. It's called INSANAT. So I used those data to do my dissertation. I know a little bit Spanish, so I could work with their questionnaire. So that's my journey with the academic journey, and then I continued to do my training. And I did a postdoc 2 years in the Institute of Human Virology under the guidance of Professor Clemente Di Bamo. And we did some research on cancer and nutrition epidemiology. He has a lot of data in nutrition epidemiology and from Nigeria. We had opportunity in this training. I also had opportunity to do case control studies, a different study design in epidemiology. So we did 2 studies using his data. We also did we recently submitted a paper of validating the food frequency questionnaire in order to collect data, nutrition data from Nigeria. So people can do more nutrition epidemiology studies in Nigeria and also in West Africa. So now we hope that it's going to be, we finished the study and we hope it's going to be published. So we have a validated FFQ to do nutrition epidemiology in West Africa. Very important. And then and so in that time, I wanted to bound to my core, my strengths. So my strength was the aging, my hands-on the geriatric as a training as a nutritionist, and I wanted to focus more on nutrition, epidemiology of aging, and I wanted to do more clinical trials. I wanted to go from the observation data and to work more on collecting data and to do some experimental data. So Jay introduced me to Professor Alice Ryan, and I moved to the VA Greg. We did several studies on sarcopenia, cognitive function, vitamin K, and also the interaction between vitamin K and vitamin D and postmenopausal women. We have a review on that. So we did also a chapter book on nutrition in centenarians that includes the blue zones. And I'm just going to say it, that the book is named Current Perspective in Centenarians, Introduction to Lifespan and Healthspan by Rhea Kerbeck and Maria Lorente. So I recommend this book. Okay, and yeah, we published 4 or 5 papers, and we built also the KO1 award that eventually was funded. So my research interests focusing on nutrition epidemiology, dietary index, biomarkers, aging, learn how to do RCTs, sarcopenia, cognitive and physical function, and infectious diseases and other implications in aging, because I realized that people with infectious diseases might be in an accelerated route to aging. And we also have a paper that we need to finish about HIV and aging and nutrition and sarcopenia. So I'm building that route, at least for now. Okay. So I'm going to start the seminar. Okay. So seminar is going to be split to 3 objectives. So first, I'm going to describe long COVID cases and their public health implication among the aging population. I'm going to explore the potential relationship between dietary intake and long COVID symptoms. And lastly, I'm going to present the nutrition randomized control trial designed to alleviate long COVID symptoms in older adults. So let's see, where do we stand now with COVID cases? So this is the COVID cases reported, new COVID cases reported to the WHO in 7 days during February 2024. So we have 82,154 new cases. Here we can see also the geographic distribution of those cases, where they come from. Of course, not all the cases are documented, so it might be even higher. I don't know why, but this dot here, it's Canada, it's not the US. The US, we have the COVID data tracker. This tracks COVID cases that were admitted to the hospital. Here we see the trend since September 2020 up to February this year. We see the overall trend. And it's also in the weekly report. We have here 19,000 COVID cases that were admitted to the hospital in 1 week. Compared to last year, it's we have like around 40,000. And compared to 2 years, we had 140,000 cases of COVID that needed hospitalization. So overall, we have a decreased trend, which is good. Here is the last week of, the 7 days in February. We can see that this 19,000 that were hospitalized. We can see their distribution across the states. I brought it because I wanted to zoom into Maryland. Maryland, in that week, they were 276 COVID cases that needed hospital. About half of them, I don't have exactly the number, but between third to half were from Baltimore City. So we know that most of the people that will have COVID eventually will have it for days, maybe for weeks, and they will recover and return to their pre-infection condition. But that's not the case for everybody. There are some people that will have consistent symptoms that interfere their daily life and their quality of life. And this is known as long COVID. If for long COVID is a little bit vague definition, because I saw several definitions, but for now I'm going to use the WHO definition, which define it as continuation or development of new symptoms 3 months after the initial SARS-CoV-2 infection, with these symptoms lasting for at least 2 months, with no other explanation. The estimated rate of having long COVID among COVID cases is 10 to 30% if they were not hospitalized, higher if they were hospitalized, between 50 to 70s. And if they were vaccinated, it's reduced, but not completely. So vaccinated protects, but not completely protects from long COVID. Even if we do the conservative estimates of 10%, there are about 65 million people having long COVID worldwide. In the United States, from other estimation, at least 9.6 million people have 3 or more symptoms of long COVID. So what do we know about long COVID? There are recognized about 200 different symptoms of long COVID that affects heart, lung, kidney, muscle, skin, and brain. And you can see here where mostly common symptoms come from. In July 2021, long COVID is recognized as a disability based on the Americans with Disability Act, ADA. It impacts the ability to work or work full-time. The economic impact is estimated to be 2.6 trillion due to losses of quality of life, earnings, and medical care spending. The most common reported symptoms is fatigue, and that's constantly, I see it in the literature and the WHO website, CDC. So it defines as tiredness or lack of energy that interferes with daily life. It also interferes with sleeping problems and general weakness. Based on meta-analysis, it shows that about 32% of COVID patients fatigue interfere their daily life, even 12 weeks post-infection.
What's the
Excuse me. Dr. Bigman, you're muted.
I pushed something.
There we go. Thank you.
I'll respond to you. So they heard your question. So I just said, you're right. Yeah, That's a good question. This is going to among people that have COVID, among people that have long COVID.
I'm going into a meeting at 1:30.
And it's also, it's not age adjusted,
I'm gonna make her the host.
it's.
Cassie, can you go on mute or?
Okay.
So it's a good question. I think gonna have a variation by age group. So it's good to keep it in mind to compare it to the general population. That's a very good comment, and you're right. Oh my God, fine.
Oh, yeah, click on that.
Okay, so we have some risk factors of having long COVID. So if you have severe COVID illness, underlying health condition, there is list of health conditions that increase the risk of having long COVID. I mentioned type 2 diabetes, but there is others. However, 1/3 of individuals with long COVID have no identified pre-existing condition. Females tend to have reported more long COVID than males, Hispanic or Latinos, as probably compared to non-Hispanic white, socioeconomic, lower socioeconomic, and insufficient rest in the early weeks after developing COVID-19. Adult under 65 years of age as well, and no COVID vaccination, full vaccination. So treatment. There is no single treatment for long COVID due to a wide range of symptoms. Usually there is expertise of physicians that treat each symptoms or cluster of symptoms. So it's a personal care that needs to be developed with the physician to reduce the symptoms and enhance quality of life. However, poor nutrition and unhealthy diet will delay and even exacerbate the long COVID symptoms. So this is where I pitch in. So what do we know about nutritional status and long COVID? So individuals with severe COVID illness are at higher risk for having long COVID, which can involve malnutrition. This may include low level of vitamin D, loss of fat-free mass, and along with residual inflammation due to the cytokine storms experienced during the acute phase of the infection. Insufficient energy protein intake will also harm muscle tissue, lead to protein breakdown, and contribute to decline in muscle mass and strength. Also, eating excessive intake of saturated fat, refined carbohydrate, and sugars can trigger even more the inflammation reaction, which can delay the recovery and of the symptoms. Here we see the suggested pathway between people that have long COVID due to COVID, unhealthy diet in their background, and pro-inflammation plus accelerated pro-inflammation reaction, the fatigue, muscle weakness, all these together will increase their risk for having physical function decline and also for disabilities. So we may have some additional ways of public health issues related to disabilities. So how to build the diet to reduce and to tolerate to long COVID people. So we want to increase the inflammatory food, the anti-inflammatory food to reduce the inflammatory reaction. So we will include vitamin D, omega-3. We're also going to include some foods that have anti-inflammatory properties, and versus we're going to reduce the index of foods that create inflammation. We're going to need to support the muscles to preserve them. So we're going to provide enough protein, energy to support the muscles. And we're going to base it on a well-known healthy eating pattern that is already was created. So in this case, it's going to be the healthy US style diet. Here is the pilot data that I collected data among long COVID patients. I wanted to know their nutritional diet quality and also their fatigue level. So I have some data on the pilot study. Here on my right side, you can see the pilot. I collected 21 patients, their dietary intake, geographic, BMI, and also if they have interest in participating in a diet program. So as you can see, on the left side is the data that were collected from the clinic. Dr. Andrea Levine gave me access to her patient, and so I could collect data from her clinic. So here we see the demographic, the age range, the average age was 50 years old, so between 40 to 60. Mostly were female, as it was in the literature. We had an even split between non-Hispanic, Black, and white. As for diet quality is measured between 0 to 100. Higher is better. So in this case, they have 65. The national level of diet quality in the US is around 60 to 63. So it was a little bit higher. The BMI was overweight and obese. Fatigue is measured between 0 to 1. The higher is worse fatigue. So if they have 4 and above, it means that they have moderate or severe fatigue. So this is all the participants in the pilot. If we take only the age 50 group, or even take the one that have and compare it to the one that have fatigue, we see some differences. I want to show it as a diagram. Oh, sorry. So here we can see the light bars where people reported fatigue 4 and above, which means they had moderate or severe fatigue. The dark gray bar is the one that did not have fatigue or mild symptoms of fatigue. And we see the difference, and the y-axis is the diet quality. And here we see the difference between those that reported no fatigue, their diet quality was around the 74, and among those that reported moderate or severe fatigue, their diet quality was around 55. So we see differences. It's not significant because we have only 7 participants and we don't have enough power, but we see some start of thinking about maybe to collect more data about it, to initiate the study itself. We also see the same trend was observed also with other component of fatigue. Mood that is above 4, it means that fatigue interfered their mood, interfered their enjoyment of life and quality of life. All this was low quality diet versus those that had quality diet did not report any mood issue, enjoyment of life, and quality. And now I'm asking as a researcher, if I will take only the people that had low diet quality, the gray bar, and modify their diet to make it quality diet, what will happen? Hopefully, they're not gonna have a fatigue if it's very similar, if they are very similar. So the fatigue level is gonna be reduced. So based on that, I want to present to you the study that I'm gonna conduct. I'm gonna call it long COVID diet. It's a nutrition randomized control trial to mitigate long COVID symptoms in older adults. The main study aim objective is to investigate the effect of 16-week nutrition and randomized control trial on mitigating long COVID symptoms and to explore the underlying mechanism. We have 3 aims. Compared to control, participant in the intervention will experience significantly lower fatigue symptoms, better preservation of muscle mass and grip strength, along with improvement in physical function. And third, increase in nutrition, a biomarker like omega-3 will be associated with reduction in inflammation biomarker, interleukin-6, for example. Let's dive into the study itself. So this is the study sample is powered to aim 1 to see significant difference in fatigue levels. We have 56 eligible men and women, age 50 years and above, with long COVID diagnosis. It's going to be a randomized control trial. 2 groups, one will receive the intervention based on the healthy style diet, and the other one will have attention control. It means that we're going to provide them some educational materials similar to one that, similar in time, that was provided to the intervention with no any dietary information. So they're going to have balance in the in that matter. Here is the intervention. We're going to use the recommendation that is already established in what's on your plate to for older adults. Here is the more specific recommendation for long COVID patients that include the vitamin D, the omega-3, quality proteins, and water. And we want to focus on the mechanism, which includes the inflammation background, the activity, and also follow-up sarcopenia or pre signs for sarcopenia. What is the recruitment plan? We're gonna first reach out to the University of Maryland Medical System, and we're gonna do first clinical recruitment. I want to have as much as people with well-defined diagnosis of long COVID. Long COVID can be, as I mentioned, the definition, the diagnosis can be, needs to be well established if you want to submit it to good papers, because they are looking for that. So it's going to be clinical recruitment with physician diagnosis of long COVID. If not going to be enough, we're going to go for other across the institute to recruit additional patients. We looked at the ICTR, and we, as for August 2022, there were 500 patients within 50 miles radius of the UMB with long COVID, defined by ICD-10 code, and who were 50 years and above. So we are looking at about the feasibility of having enough participants for this study. And still, long COVID is still here. COVID is still here. If that's not going to be enough, we're going to reach out to advertising in Baltimore using different media approach, the ELM, also newspapers, social media, senior centers to reach out for more patients, potential patients with long COVID for the study. So I'm a little bit, I like to code and I like to design. So I created this website for this study. So I can also reach out for a participant or somebody is interested. So instead of struggling each time to explain myself, go to the website and find about the study. So this is the website that we're going to use in the study. Some explanation about the study. Everything is, I took it from the informed consent that it's late English. If somebody is interested, I want to do some screening to see if he's eligible. So I have some question about his background in COVID, his fatigue, and also some diet quality assessment, but very, very simple ones. This is the link to where the study is going to be. It's going to be in the GCRC. So people that want to be involved in it, be aware that where the actual study is going to be. Here is the contact information and some atmosphere of how is the intervention is going to be. So this is another way to reach out to patients, and also to be, once the study started, I want to add the materials that the intervention will include so they can access it whenever they want, so they can be devoted and engaged in the intervention. So I have here the eligibility criteria, the inclusion, the age, the long COVID diagnosis. It has to be 3 to 6 months after infection, no active infection disease. They have to have fatigue, and they also have to have low diet quality. That will be assessed through the mini-eat as assessment, because it's strongly correlated with diet quality that is being assessed thoroughly. Including criteria, I have this list that includes some chronic disease, unstable chronic diseases, and other conditions that can interfere the intervention. So that's going to be excluded from the study. Here are the main study measurements. Of course, we're going to have the dietary recalls. We're going to use the self-assessment. I'm going to show it after this slide, but we're going to have a 24-hour recall. We're going to have also some calorie expenditure to calculate the calorie needs. So we have the resting metabolic rate. Fatigue is going to be assessment. We have a multi-dimension fatigue, so we can have fatigue, different type of fatigue, mental fatigue and physical fatigue. We have also physical function, the short physical performance battery and 6-minute walk, grip strength to measure muscle strength, and body measure and composition using DEXA. Sorry, here it is. And we're going to have also blood draw for the biomarkers and nutritional and inflammatory biomarkers. And we're gonna also include psychosocial factors as to adjust for them in the model, which include the sleep, mental health, and quality of life that associate with diet and with fatigue. So we need to also assess them to bring them into the model, and other assessment that coverage of demographic, medical history, and more. Here is the dietary recall. It's an online tool. It's available for free for the research and for the participants. It's friendly user and gives a lot of information, and it's tried to be as accurate as possible that participant can report what he ate, but also the portion size of what he ate. So they gave a variation of images to help him to assess his the portion size of each meal or each food that he reported. You get the report how far the participant was far from having a healthy quality diet. That's for the researcher information and also for the nutritionist in the field, but also participant itself can assess and see how far he is and what is missing in his diet to have more diet quality. You have vitamin, mineral. I'm sharing it because I think that people can include that in their in their research if they want to do some dietary assessment. So that's the diet quality assessment. It's needs a little bit more experience. The data management will be in RedCap. It's already uploaded. Sorry. Here's the long COVID study timeline. So now we're in the last phase of having approval for the IRB. Last Friday, they overview my IRB, so I need to wait for their decision. Hopefully, but I've been working on it like several months. We haven't started to enroll, but we want to enroll this year. And we're going to continue to enroll in 2025, 26, and in 26, we want to start publishing papers related to the data that's been collected. Here is the statistical model. We have AIM1 and AIM2. Going to use the same model. We have here the fatigue is the outcome that is in interest, the difference between fatigue before the trial versus after the trial. We have some absolute difference, and we want to focus on the intervention. So the B here, so the better one here is our hypothesis, and we want it to be significantly different than 0. All the rest is the coverts and confounders that we gonna include only if they are gonna be different than the control group. And the same matter, and same model we're gonna do to the other physical function. This model, the M3 model is to examine the biomarker, the beta 3 here, the changes in biomarker, whether it's associated with the changes in fatigue. And if that is associated, whether there is interaction with the intervention, whether the intervention has an influence on reducing the biomarkers. And that is important to understand the mechanism of our trial. And this is exploratory analysis. We have a repeated measures of fatigue. We're going to measure it in a weekly basis. This is not the result, of course. This is just a hypothesis that we want to see how fatigue is being reduced across the trial, and whether it's significantly reduced after 16 weeks, 12 weeks, 8 weeks. We want to measure that so in the future we can be more effective in our dietary intervention. So this is another exploratory analysis. And here, we're going to do also mediation analysis, as the X in our case is the intervention, the Y is the fatigue, and the mediator in this case is sleeping. It's sleeping, and it might be because it might be the causal path between diet and fatigue. So we want to check this out if it's a confounder or mediator in our model. We have some strengths and limitation. One of the problems that already we are experiencing, that decrease in COVID incidence over the 5 years, which we saw it at the beginning of the lecture. So we might need to reach out to expand our approach to recruit long COVID other than our clinic. Dropout rates could be 20% or more because of the control. People that are being attracted to the study might be disappointed if they are not going to have the nutrition intervention, and be in the control. So we're going to offer the intervention at the end of the trial to the control group, so to keep them in the trial. Maybe significant number not going to be able to perform the 6-minute walk, so we're going to do the 2-minute walk. Participant cannot tolerate the supplement, so we're going to space it not on a daily basis, maybe on every 2-3 days or 2 times a week. Vitamin D has a seasonality, so we have to make sure that we are aware of between the summer and the winter. There is a seasonality to vitamin D, and because it's been also created through the sun and through the skin. We're not going to discern between different COVID strengths. The strength of the study is in RCT. We're going to do experiment on the whole diet approach. People will modify their diet, the whole diet, to healthy eating in the healthy US style diet. We have a sample that is diverse, 50% anticipate non-Hispanic Black and 50% in non-Hispanic White. We will carefully monitor compliance with the trial through the website, through a weekly questionnaire complete. We're gonna validate the dietary intake through nutritional biomarkers. We're gonna improve the model through statistical analysis. We're gonna control for confounding by matching and by in the model itself. And eventually we're gonna enhance the understanding and the management of long COVID. But the most important strength in this trial is my mentoring team. And thank you for your support. My primary mentor is here. She's Alice Ein. She's from the professor at the geriatric and palliative care, and also at the VA Greg. So she's helping me to basically to do everything and make it happen. And I have also Dr. Beamer Barak, that is a geriatric physician. He helped me to do the exclusion criteria, the eligibility criteria, the adverse event, human risk, and to build the study. And so Dr. Monica Serras. She is from UT Health San Antonio. She has a lot of experience in older adults and dietary intervention. So she's gonna help me in that part. Professor Sorkin is helping me with the statistical plan and to do the statistical analysis and also the sample size calculation. Dr. Kyla Shia, sorry. She is associate professor at Tufts University. She's going to help me with the biomarkers, and Dr. Andrea Levine, she is helping me to recruit long COVID patients, and she helped me to reach out her clinic to collect pilot data. So I have the last slide. So the next step is in this trial is to examine specific component of dietary interventions such as fibers, vitamin K, and polyphenols. We're gonna explore the pathway between diet, fatigue, depression, and sleep. And lastly, we hope to have in the future to conduct improved nutritional intervention on large scale involving more measures and participants and using advanced statistical analysis in the aging population. Here's the references, and I'm just on time.
Great, thank you. Thank you, Galya. Let's open this up for questions or comments from anyone.
I have a question. It's not really intensive. These people have long COVID, they're 50 and older, they're living within maybe a 50-mile radius. Are you providing transportation for them to come into campus? Or they have to get themselves here?
Just a gift card when they come here.
You may want to consider having some funds maybe set aside to be able to provide transportation if that gets them in the study. How many times do they have to come in?
Twice.
So I don't know.
Not much money, okay, but she's got a gift card. I forget how much we.
Alice, you're gonna have to
I'm funding it.
dig into your pockets, Alice.
Yeah.
They're not necessarily, 85-year-olds, but when we do our hip fracture studies, we always provide transportation.
But public transportation?
Combination of things. Lyft, we've used Lyft. We used to lease a vehicle. This is not something you could do, but we used to lease a vehicle and our staff would go pick them up and bring them in.
No, I must think about it. Maybe I'll do it.
So that's an option. That's a way. So you can't use your personal vehicle to transport people, but if you lease the vehicle through our motor pool, which is down near College Park, you can actually transport participants that way.
Okay, that's good to know because that encouraged them to come.
Yeah.
I mean,
The reason why they're not joining us is because they want to come downtown.
yeah.
Because this is not a place to come sometimes.
They're going to Midtown? Will they go to Midtown or?
They go to the
Right, GCRC.
yeah,
Okay.
yeah, that you have a point there.
If I could, I just add to that, the university has a contract with Lyft. So if you decide you want to use Lyft for your subject transportation, we can work that. And Amber also noticed that, yes. So there's options out there for parking and transportation if you need it.
Other questions or comments?
I have a quick question. Thanks so much for your presentation. I was wondering, so you're enrolling people who are 50 and older, and obviously there's a lot of difference between somebody who's 50 and somebody who's 70. Did you give any consideration to sort of looking at age effects?
Yeah. I need to see how much people from each group. But yeah, if there's some potential to have an age interaction, could be. I'm not sure about. I mean, long COVID is more. The prevalence is higher among 65 years and under, and also I saw it in the clinic. So it could be that I will have some people that are 70 and above, but I don't know if I will have enough people to separate as a separate group and analyze it compared to under 70. So Yeah, could be.
Yeah, so I see. So you have the criteria at 50 because you're hoping to recruit more people essentially, and they might be kind of on the younger side of middle age.
That's where I realized when I follow up now with the COVID, because I think people are older are vaccinated, and vaccinated gives you some protection. So maybe in the future, if they don't do additional, vaccine, I don't know how long it will last, the vaccination, if they are gonna revaccinate. So that might change, but for now, based on the literature, they are more younger, 65 and younger, having long COVID and a higher prevalence. So yeah, thank you.
Other questions or comments? Anyone?
I have a question.
Amber?
Hi, this is Amber Kleckner. Yeah, so obviously not obviously to everyone, but I do nutritional interventions in the cancer population, looking specifically at cancer-related fatigue. So I think this is a really awesome study, and I'm really excited to see all of the data that you're going to get from this, and I really believe that it could work. I'm really interested to hear your thought process behind your control group. It's the control groups are things I think a lot about, because of course you want there to be equipoise. You want people in the control group to believe that the intervention is helping them in some way. Yet like all of the, it's everything is about nutrition and diet and like, what are you eating? And like, how are you addressing that? Like, how are you going to ask people to like not change their diet yet? Obviously you think it's
This is so important point. First of all, I was basing the nutrition fatigue relationship based on your studies and your colleague studies. Because I knew that there is connection between diet and fatigue in the cancer patients. So I built that knowledge and I applied to long COVID. So thank you for contributing to the science in this matter. About control groups, I know that not only that they are aware about, they have sense that there is intervention study, but also in the informed consent, I'm declaring what I'm going to do in the intervention. But I know that there's some leak in that matter between the control and the intervention. But I know that healthy diet is all over. People know about healthy diet. But to apply it and to be in a structure program, that's different. So I know that they're going to change. Obviously, I'm going to track that. But I feel that I'm hoping that the intervention will do a significant change compared to the control, so I can see differences. But yes, I'm aware of it, and then I'm going to track it, and I'm going to see how it's gonna be in the analysis, and good point.
okay. Yeah, thank you.
Other questions, comments, anyone? Well, Galya, thank you very much for joining us and giving a talk, and
Thank you. Thank you for the opportunity. Thank you for the mentor and mentor team, and for you to bringing me here and to give me this opportunity to share my knowledge and my experience.
thank you. Thank you very much.